Olá, sejam bem-vindos à TV SBU na cobertura do 16º Congresso Internacional de Uro-oncologia aqui em São Paulo. Eu sou Bárbara Melão, urologista em Manaus, e hoje estou aqui com a grande presença do Dr. Alberto Briganti, urologista do Hospital São Rafael em Milão. Thank you very much for joining us here. And I would like to talk about two recent published studies. One that was presented last week at EAU 2025 was G-RAMPP, which is a prospective multi-center study that evaluated the benefit of adding radical prostatectomy to oligometastatic patients with prostate cancer. The study was positive for its primary endpoint, which was cancer-specific mortality. So there was a benefit for patients with 1 to 5 metastases and PET or conventional image. So let's take an overview about this study, please.
So, with pleasure. The study is very interesting, and we are very happy as surgeons to have these first evidences about the role of surgery in the setting of oligometastatic prostate cancer. Of course, it's not a perfect study because the study was prematurely closed due to the results released in the meanwhile by the arm H of the Stampede, but still only 125 patients roughly were randomized out of 500 planned. Despite that, we believe that it's very important evidence that surgery may help patients with oligometastatic prostate cancer. As you were mentioning, the study is positive. The study has several merits despite being prematurely closed. One, as you were mentioning, is that they use PSMA PET in some of these patients. And there were also patients that were treated at high volume centers. And we have also some important data that we can derive. We were discussing about the fact that, for example, a non-negligible of patient rates had like locally favorable disease. Only half of these patients had node-positive prostate cancer. And actually the surgery was shown to be feasible, and the side effects of surgery, of course, are there, but certainly limited, I would say, provided that this approach is done in high volume centers. So there are very important information that we can derive from the G-RAMPP study, despite being, again, closed prematurely, and also despite having included patients with systemic therapy, which is not the one that we now give nowadays in terms of intensified approaches, but still nice evidence supporting surgery that hopefully will be published soon, and we were very happy to see these results at the last EAU meeting.
Great, and as you mentioned, and the guidelines, we have the strongest recommendation on adding radiation therapy to these patients, but it's not recommended to add surgery. Do you think it will change now with this study?
Yeah, it's a good question. So far, the guidelines include surgery as an experimental approach to be done within trials, even though, thanks to the Stampede, radiation therapy is instead suggested, as you were mentioning, as a standard of care in these patients. So the trial is underpowered in a way, in its final design, but I believe that it will certainly be mentioned, and I will believe that that maybe not recommend that there's a strong recommendation surgery in that setting, but still mentioning the guidelines with the possibility to open the door to this surgical strategy in the setting of oligometastatic disease.
Yeah. There was no overall survival, but the period was not reached, and yet we have an underpowered study for overall survival in this study, unfortunately, to the premature closure. And one other study I would like to talk about was recently published it's a study from Martini Clinic, the test that actually made a retrospective analysis of patients who underwent radical prostatectomy with and without extended lymph node dissection and had previous PET PSMA. We know that in the high-risk patients, the negative predictive value of PSMA is not quite as good and low and intermediate risk. So we should not avoid RP-LND in these patients with a negative PET, but what about intermediate risk? Well, the study had a very short follow-up, I think 36 months, which is not very good to evaluate biochemical recurrence in these intermediate patients. But what are your thoughts about it?
Yeah, I mean, the role of lymph node dissection is now again highly debated because of the introduction of PSMA PET and its negative predictive value. So many physicians and surgeons are tempted to skip lymph node dissection in cases of negative PSMA PET. But as you were mentioning, the negative predictive value is highly dependent on the disease aggressiveness. If you actually apply the negative predictive value of more than 95% in intermediate risk, I believe that you can definitely use PSMA PET to avoid a higher number of lymph node dissections in that specific setting. But intermediate risk is not a homogeneous category.
Yes.
It's very heterogeneous.
That's what I was going to say. Since now we have an update on the EAU guidelines splitting intermediate risk into favorite and unfavorite, which NCCN have already done it before, and now we see it in EAU.
So we should be careful to treat this risk group category as a whole category. We should really sub-stratify patients with intermediate risk according to disease volume, number of cores, and eventually also genomic classifiers, which are not yet that much available in Europe. I know
Not
in
here.
Brazil neither, but still they are useful prognosticators for outcomes in patients with intermediate and high-risk disease.
That's one of my critics about the study. They evaluated the intermediate risk as one group, and we know there is a highly heterogeneous group. And perhaps, I don't know my thoughts about it, the favorite intermediate risk, perhaps we should avoid, but in the unfavorable, we should evaluate better with the nomograms and other risk stratifications, perhaps.
Agree. And if you consider also the favorable intermediate risk groups, we are over-treating many of these patients. So there is a need to substratify and even avoiding surgery at all in patients with good prognostic characteristics and intermediate risk, as the guidelines are suggesting. But we may even expand indication to active surveillance in the intermediate risk, provided that patients are well counseled about the risk of progression, which is higher as compared to low-risk patients on active surveillance.
Well, thank you very much. I've always learned so much from you. Thank you for
Thank
being
you
here
very
with
much.
us.
It's a pleasure.
Continue acompanhando a TV SBU na cobertura do 16º Congresso de Uro-oncologia Internacional. Se inscreva no nosso canal para receber as atualizações no portal da Urologia.